I'm Dr. Samantha Berry, resident physician at Rush University Medical Center in the Department of Dermatology. I'm here again today with Arthur Rhodes, professor of dermatology. Today we're going to be talking about melanoma and risk factors for melanoma. Dr. Rhodes, good to see you again.
Nice seeing you again.
We're going to start with the basics. What is melanoma?
Melanoma is a cancer, and it's a cancer of melanocytes. Melanocytes are in the epidermis and the skin. They make pigment.
So when we hear about melanoma, people think melanoma is a cancer of moles. What are moles?
Moles or melanocytic nevi, nevomelanocytic nevi, those are other names. They are neoplasms, proliferations of an abnormal cell type, nevomelanocytes. And almost everybody's got moles. 90% of whites have moles. About 70% of people of color have moles. So they're very common, and most moles are totally harmless.
When we talk about melanocytes and they're collecting into these moles, what makes some people get more moles than other people?
So the tendency for having moles is a genetic trait. So if your parents are very moly, lots of spots all over, there's about a 50% chance that that's passed on to every offspring.
Okay.
So it's a genetic issue.
So looking at your parents, seeing maybe how many moles they have, may be a good indication of how many moles you would get.
At least 50% chance.
Okay. And how often do we develop moles?
Well, at birth, only 1% of newborns have a mole. And then there are studies up to age 16, 3 to 4 moles per year per person. And the study stopped at age 16. So getting moles over time is a common event.
Okay. Is there a certain age at which people should be more suspicious about new lesions coming on their body or getting new moles?
Well, there's actually never been a study of adults to see what proportion of adults out there will get a new mole or a changing mole. It's probably an uncommon event. Much more common in people who are very moly and at high risk for melanoma. Over time, probably half will develop something tiny, and it reaches a point, maybe a millimeter or 2, and then it stops. Anything that keeps going, that's a potential problem.
Okay. So if we're saying that melanoma is a cancer from moles, it's fair to say that melanomas come from either a new mole or a changed mole.
Based on studies we've done and other people have done on patients at high risk for melanoma, where we do photographic surveillance and have a baseline to compare patients to and their moles, about 80% of the time when melanoma occurs, it occurs in a mole that's there and the mole changes, usually a color change, a diameter change, or both.
Okay.
And 20% of the time, it's a new mole on skin where there was nothing.
Okay. So what are the risk factors for melanoma?
That's a whole exciting area. When I started in dermatology in the early 70s, we didn't know anything about risk factors. So the first half of my 50-year career has been in identifying melanoma risk factors, and the last part of the career is trying to identify people at high risk and keep them under very close surveillance to pick up early melanoma. Since we can't prevent melanoma, we try to keep people under surveillance if they're at high risk.
Okay.
So some of the risk factors you're asking?
Well, let's take a step back. Like, who gets melanoma?
Well, anyone can get melanoma, regardless of age, sex, gender, or ethnicity, race. So anybody can get melanoma. It's more common in people with white skin compared to people of color, but anyone can get melanoma. The distribution where they occur is a little bit different based on ethnicity and color, but anyone, any age can get melanoma. It's rare in children, maybe 1 per million per year up to age 12. After that, it's about 30 per 100,000, 1 in 3,000. Per year, white adults will get melanoma. It's 20 times less common in people of color, African origin.
So do different races tend to get different types of melanoma? And if so, what are those types?
Well, 10% of melanomas in white people, occur on the hands, the palms of the hands, soles of the feet, nail beds, mucous membranes, mouth, conjunctiva of the eyes, genitalia, and perianal area. And in people of color, it's 50% of the melanomas will occur in those non-sun exposed sites.
Okay. And then what are the different types of melanoma?
Well, there's more than 5 different varieties of
Okay.
melanoma. I'm not sure how much detail we're going to get into, but some are clearly caused by sun, about
Okay.
5 to 7% of melanomas in this latitude, and maybe 20% in the southern regions of the United States. It's called a lentigo malignant variety of melanoma on severely sun-damaged skin. They look like a shoe polish stain.
Okay.
Rarely a red patch, but it's usually a brown, dark brown, variegated brown colors on the sun-exposed sites.
Okay.
And of those, and they're flat to begin with, of those maybe 5% go on to develop melanoma. So that's a precursor or an early melanoma, and there's a little argument what we call it.
So we started talking a little bit about risk factors for melanoma. Can you elaborate on that?
Well, the most important risk factor that anybody should recognize is a new mole or a changing mole. And the change is a persisting change that continues to change, as opposed to moles that normally come, they start tiny and remain tiny in adults. Only 1% of newborns have a mole, and they're generally pretty big, at least the size of a dime or bigger.
So what about atypical nevi or atypical moles? What are those?
Well, this was recognized in the mid-70s, 1970s. And it was recognized in families, 2 families actually, and published, and it was called a certain syndrome, BK mole syndrome. These were 2 families where the actual families came to the doctors and said, we think having lots of moles have something to do with melanoma.
Huh.
And these were big, irregular moles, and family history of melanoma in 2 or 3 family members. So it was published, and another paper the same year came out with the same information. And at least my early work had to do with whether this was a general phenomena, that atypical moles were present in a certain proportion of the population, even without a family history of melanoma. And we found that to be true. And we found that at least 20–30% of melanomas arose in an atypical mole. And these atypical moles run in families. So if a parent has the trait, passing it on to the child is about a 50% chance.
Okay.
So it's a general phenomena. These atypical moles tend to run in families, and they account for about 1/3 of melanomas.
So what is an atypical mole?
An atypical mole tends to be bigger than normal, so 5 millimeters, size of a lentil bean or bigger, with irregular pigmentation, maybe fuzzy margins, and they just look a little odd. And they tend to be multiple, so multiple large moles. So people who are very moly, they generally have these atypical moles. And having a lot of moles falls under the same category of atypical moles.
Okay. What about a personal history of melanoma?
If you've had a melanoma, you have about a 900% increased risk for another one. If you have a family history of melanoma and a first-degree relative, it's an 800% increase risk for any first-degree blood relative. So it's a familial trait.
So that sounds really like there is a strong genetic component driving one's risk for melanoma.
A very strong genetic component.
Do we know any of those genetics?
Well, the most popularized one was something called a P16 mutation,
Okay.
where there are multiple members in a family with melanoma. There's also a high risk for pancreatic cancer. And it's about 20% of patients with melanoma in the United States, 10 to 20% will have that mutation. And the only thing different in terms of monitoring those patients, because anybody at high risk with abnormal moles needs to be followed, but pancreatic cancer is an issue, and certainly the issues related to that have to be discussed.
Any other cancer syndromes that are in association with melanoma?
There are other cancer syndromes. I'm not going to give you all the abbreviated genetic terms, but there's a higher risk for thyroid cancer, kidney cancer, eye melanoma. Those are the big ones in addition to pancreas.
Okay.
There's an increased also risk for breast cancer.
I was just about to ask.
Yeah, with certain mutations that are related to breast cancer, there's an increased risk for melanoma. We're examining all the breast cancer patients for high-risk moles and early melanoma.
Okay. Is there any genetics that people should have genetic testing, things like that, for their risk for melanoma?
I think that's beyond this discussion,
Okay.
and that's something that should be discussed with the diagnosing physician.
At that time. Since we're talking about risk factors for melanoma, what about congenital nevi or congenital moles?
So congenital moles are present in 1% of newborns, usually the size of a dime or bigger. The really giant ones, it's about 1 in 500,000 births. So it's 1% to 1 in 5,000. They are clearly potential precursors for melanoma. When we looked at pathology of over 200 melanomas, 2.5% to 8% had the pathology of a birth mole right at the same slide, same section as the tumor. So by history, 15% of melanomas arise in a birth mole. Now, birth moles occupy a very tiny proportion of the body surface. To have melanoma and congenital nevi in the same spot, with only 1% of the population having them, it's occurring 14,000 times greater than expected. So it's a potential precursor.
Do you have a recommendation for these congenital nevi?
Well, if that is the only problem, and there aren't atypical moles, and congenital nevi do run in families. So if that's the only issue, we generally follow them until they can be removed at around puberty, when kids can cooperate with the wound care. And this is a controversial area. Some doctors say, well, just follow them, and if they change, then come in. I like to get rid of them or follow them every 6 months for life.
So no overall consensus in the field?
There's a lot of argument, disagreement, and controversy about small congenital nevi because it's 1% of the population.
What about something called a Spitz nevus?
Sophie Spitz described a tumor that looked like melanoma in children, but the children generally did very well. And the pathology of that tumor, and we call it a Spitz tumor now, was described in 1948. They are very difficult to assess under the microscope. They can be very, very confusing. We call them epithelioid and spindle cell tumors.
Okay.
And we put Sophie Spitz's name to it. So if you have one, it's an 8-fold increased risk for melanoma somewhere on the body if you've had a Spitz tumor. And they seem to aggregate in the same families where there's somebody with melanoma. So that should ring a bell. Anybody has a Spitz tumor, the whole family should be looked at.
So we're talking about new or changed moles. What are the ABCDEs of melanoma?
So the ABCDs of melanoma is a mnemonic that the American Academy of Dermatology has been promulgating. A standing for asymmetry. And this is to diagnose early melanoma by yourself as a public message.
So if you're looking at home, this is the mnemonic to help you know what to look for.
Right. I think it's a very complicated issue because it's not intuitive.
Okay. What does it stand for?
A stands for asymmetry, one side of the mole not the same as the other if you cut it in half.
Okay.
B for border irregularity. C for color variegations, multiple colors. D for diameter greater than a pencil eraser, which is 6.5 millimeters, a little bit
Rather
bigger
large.
than 1/4 of an inch. And E was added after a bit of controversy by myself and one of my colleagues to get rid of the ABCDs because it's not an intuitive message. It's too analytical as a public message. So they added E for evolution, something new or changing, which is a more an intuitive message. I'd rather stick with the intuitive message. It's simpler. The others, too complicated. In addition, too many melanomas don't fit the ABCDs at all. About 20% of melanomas are red or non-pigmented at all. and a good proportion are smaller than the diameter of a pencil eraser when they're early.
And let's not wait for them to get to that size.
You don't want to wait until they're advanced and bigger. So I'd prefer a new or changing mole as a public message. If it doesn't go back to normal or it's continuing to change over the next 3-4 weeks, you probably ought to see your doctor.
I feel like patients always come in and ask us, what can they do at home to modify their risk for melanoma?
So regardless of any mutation that's there, we're going to be doing everything the same for everybody, regardless of whether there is or is not an abnormal mutation. That's why I'm not in a hurry to get genetic testing. Everybody has to be looked at periodically with a head to toe, every nook and cranny kind of examination. All the family members have to be looked at because it is a genetic issue. We recommend reasonable sun protection measures for everyone, regardless of risk. Telling people not to burn in the sun, that's common sense. And we do what we need to do to keep from burning. You know, clothing, sunscreens on non-clothed sites. So that's sort of common sense.
So we recommend for patients to sort of keep an inventory of their skin, right? And look for anything new, look for anything that's changed by looking at their skin at home monthly. What are they looking for?
Well, the self-examination with a partner or a buddy to look at the areas you can't see. You can't see your back very well in the mirror. You can't examine your scalp. Melanomas in the scalp are usually diagnosed very late, so we encourage at least having a partner or your beautician or your barber to look through the scalp, make sure there's no hidden moles, because they have to be watched. So you'd have a partner watch your back, buttocks, back of your legs, back of your thighs, areas you can't see.
So melanoma can occur in all of those areas. Sounds like in the scalp. What about in the mouth? What about in the private areas?
We saw a patient recently with melanoma on the tonsil. You can have melanoma on the tongue, on the gum. You can have melanoma on the conjunctiva, the eyelid, behind the eye, on the eyeball, in the white of the eye, your iris, the colored part of the eye, and in back of the eye. You can have melanoma starting on the lining of the brain, leptomeninges, in the middle ear, the sinus, inside the nose. But they're a tiny proportion of melanomas. Most melanomas, the vast majority, occur on the skin where you can see them.
So let's say somebody finds something at home. When is it time for them to come in and be evaluated in office by a physician?
If you are concerned about a mole, that's a phone call, and you got to push pretty hard to be seen.
Okay.
Melanoma, you do not want to wait until it's bleeding, itching, pain, or bleeding. That's an advanced melanoma. If you're suspecting a problem, it ought to be seen. In the old days, in the 1950s, the public message used to be if you have a mole that's bleeding, painful, oozing, itching, see your doctor. So patients did not see their physician until they had moles that were doing those awful things. And half the people were dead in 5 years. Now, when we're diagnosing melanoma, when it's asymptomatic and early, 95% of people, 98%, are alive and well 5 years later. So we've turned that around by trying to diagnose early melanoma. And the epidemic actually started with a paper in the New England Journal of Medicine, 1973, where 19 melanomas were shown in living color. That was the first color for the New England Journal of Medicine. And that article was sent to every physician in the United States. That was pre-printed by the American Cancer Society. The melanoma epidemic took off at that point. So it was an issue of recognition of what early melanomas look like.
I have a lot of patients that come in and they say, you know, I hit a certain age, I felt like I should at least be evaluated by a dermatologist, or I should be seen yearly. Who needs to be coming in? When do they need to be coming in? And how often do they need to be coming in for full body skin exams?
Well, the skin exam is part of the physical exam by your general doctor.
Okay.
Now, you may or may not have it, depending on the amount of time and the issues that are brought up. But a skin examination takes about 2.5 to 3 minutes to do a very careful exam. And it can be done quicker, at least with a quick look on the main areas. If you're concerned because you have a family history of melanoma, or you have lots of moles, or you're just concerned about a specific mole, I think your first recourse is your physician. To call your physician, say, I'm concerned about a mole. And if your physician is uncomfortable with it, they'd get their favorite dermatologist to get involved.
So, what about the role of sun in melanoma?
The role of sun in melanoma has been bandied about for well, at least since I've been in medicine, which is 50 years, and even before that in the 1950s. The sun clearly has a role with the lentigo maligna type melanoma that I mentioned on sun-damaged skin. But again, it accounts for 5 to 7% of melanomas in the Chicago area, maybe 20% in the southern climates. And that's where that shoe polish stain or that abnormal patch appears on a severely sun-damaged site. And those patches can give rise to an invasive melanoma.
So what should people do to protect themselves from the sun? One of my favorite things is sun protective clothing. Do you have anything that you recommend?
I think when it's a lot of sun, I think double layered clothing is the smart thing to do. And if you don't want to cover your face, I'd use a sunscreen if you're going to get a lot of sun. Otherwise, you're going to burn, get sun damage, and then we're talking about squamous cell carcinoma, basal cell cancer, as well as actinic damage called actinic keratoses, which are unsightly, scaly red patches, some of which turn to squamous cell cancer. And they can be a real problem.
So if you're looking for sun protective clothing, what you're looking for is items that have something that's a UPF and they have a rating with a number next to them. Is that correct?
Well, you should know that a common t-shirt permits about 40% of ultraviolet going right through. A double covered is the way to go unless you're using sun protective clothing, which may be expensive for some people.
Can be. What about sunscreens? Tell me about the different types of sunscreens.
Well, the whole purpose of sunscreen is to reduce ultraviolet radiation getting into the sun and all the wavelengths, the burning wavelengths, the skin cancer wavelengths, as well as those that are the less risk to cause skin cancer. We have very good sunscreens available to us today. The only problem is there are some side effects of some of the organic sunscreens that can be absorbed through the skin.
So let's talk about that word organic, because I think when most people hear the word organic, they think, farm to table, grown without pesticides, things like that. But when we say organic, when we're talking about sunscreens, we're talking about, carbon chemistry, essentially.
We're talking about chemistry. And the organic sunscreens are a problem because the FDA recently did their own studies, and it was published about 3 or 4 weeks ago, and they showed that the organic sunscreens, the main ones that are being used in sunscreens, are all absorbed, and they're blood levels that are detectable.
Right.
And at this point, the studies have not been done to see whether those organic chemicals have an effect on a developing brain of an embryo. It's clearly in the breast milk. It actually affects sperm function and is reducing fecundity, the ability of men to get women pregnant. There are studies out of Scandinavia showing that. And it also is affecting the coral reef, bleaching of the coral reef, and possibly affecting the habitat to the point where Hawaii, they're banning certain organic sunscreens, also Key West, Palau, and Australia. They're banning the organic sunscreens.
Okay. So what types of sunscreens should people be looking for? So let's say you're trying to avoid organic sunscreens and you're looking for a good quality sunscreen to use.
You want a safe sunscreen that works.
Okay.
And I don't know if people remember, the lifeguards used to put zinc oxide on their nose, on their noses to prevent burning. Well, the zinc oxide chemistry has been evolved so that the inorganic sunscreen, the mineral inorganic sunscreens, are either zinc oxide, titanium dioxide, or both.
Both together.
And they're in formulations that are pretty reasonable when you put them on the skin, so they're not too pasty looking. And they are effective, and they can be used on women who are pregnant. They can be used on very young babies. they're safe, regarded as safe, and the FDA regards them as safe because you don't get blood levels with them.
Okay. So if I want to not get melanoma, do I have to stay out of the sun?
I think it's just common sense about going into the sun. Everybody has to live. You want to go out, get fresh air, exercise. Yeah. It's just smart to, change your behavior so that you're not burning. And that's clothing, sunscreens, but I think fresh air, exercise are very important for your body and your mind.
Because another question I feel like I get a lot from patients is, what about vitamin D? The sun's role in vitamin D and vitamin D's role in their body.
Well, vitamin D is actually a hormone. Every cell in your body has a vitamin D receptor, and it clearly has a role not only in bone and muscle health, but it has a role that appears in cardiovascular disease, autoimmune diseases, cancer. The lower your levels of vitamin D, there's certain cancers that there's a higher risk. And you can get vitamin D either from the ultraviolet, and that's the ultraviolet B in the sun, which is only 5% of the energy, acts on precursors in the skin to make vitamin D in your skin, and that's changed again in your liver and then your kidney to active form, so it can be used throughout the body for those different functions. If you're not getting sun, and I'm not pushing sun to get vitamin D because it's kind of erratic. If you stay out too long in the sun, the ultraviolet A, which is 95% of the energy, actually destroys what the ultraviolet B makes in the precursors on your skin. Otherwise, you'd be toxic from vitamin D going out in the sun. And there can be too much vitamin D from oral intake of too much vitamin D. So it's sort of a homeostatic mechanism so you don't get toxic from the sun making too much vitamin D. So it's a sort of
it's a balance.
It's a balanced mechanism.
So what are other ways to supplement for vitamin D if we're not using the sun?
Okay, if we're not using the sun, and I'm not pushing the sun for vitamin D only because it's erratic.
Yeah.
Actually, a third of skateboarders and surfers in South Florida are insufficient in their vitamin D levels in their blood.
Not reliable as a source for
It's not reliable. So it's either supplements or wild fish. Okay? And I'm not pushing wild fish in Chicago because
not fresh, huh?
I like fresh, and it's got to be certain kinds of fish and oily fish.
Oily fish, so
Yeah,
fishes
from the
like
ocean.
salmon.
Salmon, sardines, halibut, but ocean fish.
Ocean fish.
Yeah.
And is it because the wild fish have a higher proportion of oils and vitamin D than farmed fish?
Apparently, the diet of ocean fish is different than the freshwater or the farm-raised fish. Farm-raised fish don't have very much vitamin D at all.
What about vitamin D supplements?
The vitamin D supplements, you can get toxic from taking too much. So you would discuss the amount with your physician.
Okay.
I can tell you what I take, but that may not be relevant to most of the audience.
Okay. So the first step, consult with your primary doctor.
Because there's a
about
toxic dose. The 10,000 units of vitamin D is toxic.
Yes.
So we're talking for children anywhere from 400 to 1,000. For adults, depending on the size of the adult, anywhere from 2,000 to 4,000. And the more obesity there is, the vitamin D goes to the fat, not even available to the blood level. So that may require more, and of course weight reduction. As your weight comes down, your vitamin D dose is going to drop as well.
Thank you, Dr. Rhodes, for chatting with me today about melanoma. We hope that you found this helpful. Our real message today is anything new or changing on your skin that's not improving or getting better in a couple of weeks really needs to be evaluated. Again, I'm Dr. Samantha Berry. This is Dr. Arthur Rhodes. We're at Dermatology at Rush. Hope you have a wonderful summer.